Yeah, well, that was my flatmate's Instagram story from like a long time ago, and then he managed to just randomly, no context, still not telling me where he got it. I thought it was sources, though. Yeah. So you can live stream that? Probably. Okay. Yeah. Okay. I'll keep my Dakota chat to a minute.
Dakota chat's really good.
That's right.
New bag. Refresh. It's refresh new bag.
This one here? No, I got it last year for the World Cup. So it's been lugging through Tokyo Underground. It's been rolling. You good here?
Well, kia ora koutou katoa. Welcome again to the Ministry of Health and today's media update. I can start by confirming there are no additional confirmed or probable cases of COVID-19 to report in New Zealand again today. To date, then, New Zealand has had the 5 positive test results and we have 2 probable cases. As I've mentioned before, these confirmed cases fit the pattern that the WHO is talking about around spread primarily within families. Of the positive cases in New Zealand, one of those is in Auckland Hospital and continues to improve. That was the first case that we identified in New Zealand, and planning is underway for that person's discharge. And of the other current cases, none are requiring hospital level care. Also, I can provide an update on the New Zealanders who were on the previous cruise of the Grand Princess cruise ship. That was the cruise from the 11th to the 21st of February, and that's the ship that is currently, I understand, being docked or going to be docked in Oakland so that the US authorities can deal with that situation. So, as you know, on Friday we were notified about 8 New Zealanders who had been on that previous cruise. Of the 8, 5 are well and have passed the 14-day period of concern. 2 other passengers, 2 have been tested, and 1 test is negative. The other result is still pending. The person who is one of our probable cases is a woman in her 70s who is still in North Shore Hospital being treated for a non-respiratory condition, but she was in hospital from the 25th of February when she returned to New Zealand for a respiratory illness, that despite negative testing for COVID-19 is being treated as if it was a case, so it is a probable case. As you also know, a number of close contacts, including staff at North Shore Hospital involved in her treatment during that earlier admission, are currently in self-isolation. The total number of staff who have been asked to go into self-isolation is actually 54. All will need to be well before they return to work. The first staff members were exposed early in the period of her admission, and so will be coming back to work by this Wednesday, the 11th of March, and other staff will progressively return to work, if they are well, as their 14-day period since they were exposed to that probable case expires. And all staff will be back at work by Monday, the 16th of March, which is a week today. Waitemata District Health Board has assured us that there has been no impact on clinical care from those stand-downs. They have been able to find other staff to fill those rosters. Now, there are a number of other cruise ships or ships that are in the news at the moment, And just an update on those, there are 4 New Zealanders currently on the Grand Princess in San Francisco or off San Francisco. We are not aware of any health concerns around any of those people. 13 New Zealanders are on board the quarantined MSC Opera off the coast of Greece, and also we are not aware of any health concerns for those New Zealanders. There is 1 New Zealander on the Asara on a Nile River cruise that's quarantined also. We're not aware of any concerns around that individual either. In terms of the number of tests, we've had the 5 positive tests. We have the 2 probable cases that have been tested and have returned negative, and those are part of 269 negative results, and there is a number of people who are undergoing testing at the moment. Those are a mix of people who are possible cases and also some symptomatic close contacts of existing cases. I don't have details around that, but just to say also that one of those negative tests is, of course, the person who was the father of case 3 and the father-in-law of case 5. So he was tested. He had travelled from Iran, and that test was negative. This week, our laboratory testing capacity will increase substantially as Lab Plus in Auckland is scheduled to increase its capacity from 60 tests per day to as many as 750, should that be required. So combined with the other testing capacity we have in Wellington and in Christchurch and now in Dunedin, we're able to process well over 1,000 tests a day, should that be required. I am happy to take any questions at this point.
Just for the processes with the 4 New Zealanders that are on board that Grand Princess due to dock in Auckland, what will they be required to do with coming home? Will they be put in isolation back here in New Zealand?
My understanding is that actually the US authorities are going to require people, either crew or passengers on that ship, to undertake quarantine as appropriate over there. My further understanding is that those 4 New Zealanders are actually crew members, so they would be managed along with the other crew.
They won't do anything when they come back?
Not if they have been in isolation for 14 days since they were last possibly exposed to COVID-19.
Of the total number of tests that you have done, how many of those tests have been conducted on people that aren't related to either the probable or the confirmed cases?
I don't have that number. What I can say though is, and I talked about this late last week and on Saturday, that we're at that point where we're actively case finding now, and in fact we would be moving to do wider testing of possible or probable cases, even if there wasn't necessarily a travel history or a history of exposure to a confirmed case, but if the clinical suspicion was there, recalling that we now have an increasing number of countries overseas that are reporting increasing numbers of cases. I don't have the detailed breakdown of how many are close contacts of confirmed or probable cases.
And so you're kind of working towards tracking a community outbreak should it reach that testing wider than what you tested?
What we're now in the phase of is active case finding, so we're working with primary care to see what support they would need to just increase the number of testing, so we are not missing cases. And what we have seen in a number of countries, and I'd point particularly to, or jurisdictions, so Singapore and Taiwan, is that with that really active case finding and self-isolation, you can prevent that onward community transmission, and that's where we're really going to focus our efforts.
Are you looking at doing drive-through clinics? What's the situation there?
It's one of the options on the table. Our first priority is to use our existing primary care infrastructure, which is general practice. We've got over 1,000 practices in New Zealand. They've got PPE. They've done this before when we had the swine flu outbreak in 2009, so it's really gearing up our existing infrastructure, then looking to see if we may need to complement that with you might call drive-through clinics. We're calling them CBACs, community-based assessment centres, or fever clinics as they call them.
Will it need to reach community outbreak level to actually see something like a drive-through clinic though?
Not necessarily, no. I think one of the things that we've learnt about, well, 2 things about the pattern of this virus and how it behaves that is different from influenza, that is influencing our response. The first thing is the evidence that asymptomatic transmission plays a very small role. So people transmit the virus when they're symptomatic. The second thing is that the period of time from when a person infects another person, the period of time till that second person becomes symptomatic is quite a long period of time. It's 6 to 7 days, whereas with influenza, it's 3 to 4 days. So there's a longer period. We've got a window where we can contact trace close contacts and get them in self-isolation. So that means that our focus on this sort of stomp it out and is even stronger, and we'll be going really hard on quite intensive efforts to contact trace and isolate people.
Do you know when they would likely be up and running, these drive-through clinics, if you do confirm or if you decide to roll them out?
It will depend on the situation. Really what we're doing now is developing a range of options that are right through from how we strengthen the contact tracing, through having more people able to do that, through what options we've got in primary care, including drive-through clinics, you might want to call them, through to what options we might have around mass gatherings, around quarantine, around even, and you've seen quite drastic measures just introduced in northern Italy now. I think what that shows is that all options need to be on the table, and so what we're working through is the detail of what each of those options would look like so that they can be deployed at the right time.
Going back to the Kiwis on cruises, just for that River Nile cruise, the Egyptian government had said that for anyone that had tested negative, they would be sending them back to their countries within 24 hours. If that was to happen, would that person then be put in isolation here?
Yes, we would ask that person to self-isolate for 14 days and supervise self-isolation.
So whakaparaoa?
At home, I would imagine, in that situation, and with regular contact, just as we are now with close contacts of our existing cases. So if someone's tested negative, but they're clearly a close contact, that would be at home and supervised self-isolation.
How many people who were at that tour concert are now in self-isolation?
Well, the only people who were close contacts were the people who were the friends of the index case there. The others, everyone else was classified as a casual contact, so we're not requiring or asking them to go into self-isolation, merely to be very aware of what the potential symptoms are and to seek medical help if they develop any symptoms.
What's been done to make sure hospitals don't get overwhelmed? Dr. Deborah Powell has said that she's really worried about DHBs and the whole hospital system is really stretched. That's a quote from her.
Well, I think 2 points. One is, I think you want to understand why Deborah might be saying that, and that is that she's in the middle of a number of contract negotiations, so that's the context there. The second thing is, right from the start, we've talked about the need for our hospitals to have really good plans and primary care to ensure that we can cope with cases of COVID-19 as they come through. Of course, with our contact tracing and intensive contact tracing and self-isolation, what we're trying to do is reduce the number of cases, and that reduces the impact on hospitals, and also, of course, to ensure that as many of our susceptible people as possible get their flu injection this year. I have talked with Deborah, and she's agreed that what we really need is good ideas about how to address pressures in the hospital system, not simply restating the problem.
But if you take 50 nurses out per one case, that's a lot of nurses just for one case. If more cases start to hit hospitals and you're talking about hundreds of nurses having to self-isolate, surely the hospitals can't function if that happens.
Well, that's why we've got the active case finding going on and clear information to people if they are presenting with symptoms and they think it could be COVID-19. Ring Healthline, call ahead to their GP if they're turning up there. And these are all things we did in 2009 with the swine flu pandemic. And as I was saying the other day, if Healthline has someone on the line who they think is a possible case, then they don't just say, go to the ED or go to your GP. There's this warm handover. They get them on the phone. There's a three-way conversation so that the hospital can be ready for someone coming in.
But are there emergency procedures kind of being put in place? Like when we saw the junior doctors strike, you had doctors being hauled in, being paid double time because the hospitals were overstretched. And those kinds of things being looked at here as well to make sure you can pull in as many staff as you can, because if it does happen.
Sure. So I think the difference, say, with the doctors' strike or, for example, the terrorist attack in Christchurch a year ago, that this is a long-haul thing. So we need to think about how might we strengthen or increase the workforce for a period of months rather than just a few days. And one of the things we've actively looked at is bringing in people who might have recently left the workforce, including through retirement. And by way of example, there are 8,000 nurses who have had a practicing certificate within the last 5 years but no longer do. So there's quite a pool of nursing staff. There are 146 GPs who had a practicing certificate in the last year but no longer do. So there are people out there, and this is one of the things we're actively working on to ensure that we could get those people back if they were willing to, of course pay them, but make sure they were registered to practice.
Are you aware that APEX are saying that their members are planning on strike action on Friday?
Sorry, this is the laboratory
Yep.
workers, yes. Yes, I am aware of that, and another conversation with Deborah Powell today. So 2 comments I would make. First of all, that strike, if it goes ahead, will not affect our laboratory testing for COVID-19. Either the workers are not in laboratories like ESR, they're not no members in that laboratory, or where they do have members in the Auckland laboratory, they're not involved in COVID-19 testing. The second part of the conversation I had with Deborah Powell was that I'm just disappointed that they are using this situation to get leverage around an industrial matter that's been ongoing since last July. That doesn't mean that we don't want to resolve that matter, but I don't think now is the time to be trying to use this as leverage, and I think that's pretty disappointing.
What if any changes are being considered for travel restrictions to leave Australia, EMEA?
Yeah. So Cabinet are considering advice today, and in particular it's the weekly review of the current restrictions that involve China and Iran, people who've travelled to China and Iran, and they will also be considering any other restrictions. So I don't want to preempt their discussion or decisions, and I'm sure the Prime Minister will talk to that later today.
So you won't say which countries are being considered?
It could be a whole range of countries, but I'm sure there'll be quite a wide discussion because also, of course, there were further developments over the weekend. We've seen an increasing number of European countries with cases, and I should say on that matter, we've asked for some urgent advice from our technical advisory group about whether we should add further countries to Category 2 in our categorisation in terms of possible exposure through travel. And in particular, Cabinet will be considering those Category 1A and 1B countries today.
If we look at suspected cases and probable cases, I think you said you didn't have exact data on that at the moment, but can you just break those down and explain how and if they overlap?
Sure. So a suspected case is someone who fits the criteria of travel exposure or exposure to a confirmed case and has symptoms consistent with COVID-19. So that's before they're tested. If the testing is positive, then they become a confirmed case. If the testing is negative and we think still that there's a strong clinical suspicion based on the travel history and the symptoms, as is the case with our person who's in our North Shore Hospital, then that becomes a probable case. So basically, all the professional consensus is that this person has had COVID-19, but the laboratory testing didn't confirm that.
So are you able to tell me now how many people are suspected cases after contact with a probable case?
No, I don't have that information. But what I can say is, of course, that of the 5 cases, anyone who was a close contact who was symptomatic when they were contacted would have been tested. And so far we have had only negative tests over the last 2 days.
Did you say the testing and capabilities are ramping up this week?
Yes, this week. At the Auckland Lab Plus laboratory, yes.
And then for drive-through testing, I know it's still an idea being considered, but could we see that potentially later this month, or will it be next month? Is there any time frame?
No, I'm not going. That's just an idea at the moment. And I should say that the testing is not done in the drive-through clinic. The test is undertaken, so the swabs would be taken, but all the testing would still be done at laboratories.
When you're talking about the capacity of the testing, and you talk about 1,000 tests per day, what you're ramping up to, how many patients does that equate to? Does it equate to 1,000 patients?
Well, it would equate to, the testing would be done on different groups of people, so it might be people who are possible or suspected cases. It might be people who are close contacts of confirmed cases, and some of that testing would be what we would call for surveillance purposes. So, for example, even from last week, anyone who was in an ICU who had a severe respiratory infection and was being tested just to see if it was COVID. This is part of what we call surveillance. And likewise, as we head into the influenza season, we have a network of general practices around the country called Sentinel General Practices that every year they will swab anyone who comes in, do a throat swab on anyone who comes in with what we call ILI, influenza-like illness, to see how many people have got actual influenza and which type, whether it's influenza A or influenza B. So what's happening this year is that swabbing we will add COVID-19, and that gives us a really good mechanism as we head into winter to find out is there COVID-19 out there in the community.
I'm basically asking if it's one swab per person. Is it one test per person, or are you doing more than one test?
Oh, it's one test per person, yes, although they would take different samples to ensure that they've got both a throat and a sputum sample if indicated.
Would you say it's safe for Kiwis to fly at the moment? We've seen in New Zealand reiterate almost on a daily basis at the moment how dire their situation is. And you've said in the past you only really have to worry about 2 rows in front of you, 2 rows behind. I mean, would you suggest if your mother was wanting to catch a flight, or aunt or auntie or child, would you say it's safe to travel? Or
even myself, I'm planning to fly this week. Yes, it is safe. Remembering we've got 5 cases in New Zealand, and whilst travel on an aircraft is a situation where there's a possibility of being a close contact of a case, the evidence from research done by Michael Baker 10 years ago show it's still very unlikely, even if you're in one of those rows near a case, excuse me, that you will be infected. And secondly, as you've probably heard the New Zealand Chief Medical Officer say, and others, modern aircraft have fantastic filtration systems in their ventilation system that filter out viruses.
As the testing increases, is that going to slow down some of the other day-to-day testing that's done in labs?
No, it wouldn't, no, because it's a separate assay, a separate machine, so all the other testing would continue. But what I can say, of course, is this is important, so labs would ensure that it was being done as a priority each day.
Did you say there were also Kiwis on a cruise ship in Greece?
Yes, I understand. What my notes have got is that there's a cruise ship, is it the Opera, that is being held off Greece, and there is a number of Kiwis in that, on that ship. Let me just... 13 New Zealanders on board that, not aware of any health concerns. And of course what would happen would be the local consul would be reaching out to any New Zealanders on board that ship and just seeing if they needed any support or if they had any symptoms.
Would they have to be isolating back here, or is it not a category 2?
It's still quite early in the development of that particular situation, so we'll just keep a close eye on it and update as we get further information.
Sorry, just back to the APEX strike. Was it your advice to the union organisers that they shouldn't be doing this?
I suggested I didn't think the timing was very good.
How much did you push back on them? How strongly did you push back?
It was a fairly robust discussion.
Could you give a few more details about what you mean by robust?
I told Dr. Powell, and we've known each other for a number of years, that I just thought it was poor timing, and that didn't mean we didn't want to resolve the industrial dispute. Of course we do, but I thought it was poor timing to try and draw in the response to COVID-19 into that particular disagreement. Any other questions?
Has the period changed for what you are thinking for?
Well, over the weekend we updated the case definition. I think there were 2 main differences there. The first is the testing that I just talked about of anyone in ICU with a severe acute respiratory illness. It's called SARI. Now we're broadening that to test anyone in a hospital who might have that illness as part of surveillance. The second main change was we just reiterated, and it's been there from the start, that even if someone doesn't fulfil the criteria exactly, that clinical judgment should always apply, and that if they have a strong suspicion, a clinician shouldn't hesitate to test.
And we just still
One
haven't
more question.
seen any specific places come out about where people who are confirmed cases have been. Is that because there's no cause for alarm, or are you keeping that on the down low?
We've been very open about the schools involved, a concert, so definitely not keeping it on the D-low, but all the close contacts have been contacted and have been in self-isolation since they were contacted, and remember they're on daily check-ins to check that they haven't got any symptoms.
How many people are that are in self-isolation as a result of those close contacts? Have
I did give the numbers yesterday, and they have changed very little, but we can make those available once again as a follow-up. Thank you very much. I appreciate all the attention and interest. Appreciate your support.
Thank you.